Invitation on behalf of Regional Center Bhubaneswar, on behalf of our Senior Regional Director Dr. S.K. Tripathi, on behalf of School of Health Science, on behalf of Vice Chancellors, I welcome you, ma'am. Definitely, today's session will be one of the interesting session for all of us. Interaction, infection, and control management. Ma'am is going to discuss about all these things because I am not the specialization persons for this course. So, ma'am is very much academically, she is very sound. She is a very good human being. So, I thank you, ma'am, once again on behalf of Regional Center Bhubaneswar. I welcome you and I hand over the session to you, ma'am.
Uh, Good afternoon, everyone. Thank you so much, sir, for such kind introduction. And before I start, may
Yes,
I know, am I audible?
yeah, you're audible and you can start, ma'am.
Thank you, sir. Thank you. So the topic which is being given to me is integrated hospital infection prevention and control management. So before I start, I'm hereby sharing the circular which was released from my institute in the month of August, where this HICC team was constituted, and I was being given the post of member secretary of this committee. And I'm a senior microbiologist of 15 years experience, and that is why, as per the NMC, which is the regulatory body of the medical colleges, they have clearly mentioned that senior microbiologists should hold this post, and the other members from different disciplines were included. So, why this committee was required? What was the need? That is my primary objective, which I want to convey in my today's lecture. So, what is infection prevention and control? That is IPC. So, it is a practical, evidence based approach preventing patients and health workers from being harmed by avoidable infections. So, nowadays we are hearing a number of hospital acquired infections, healthcare associated infections. Their number has increased, and if we have a better IPC team, IPC practice in our institute, we can always prevent these infections. They are avoidable. So this type of practice, it is important for the patient safety and quality of care, and it is relevant to every healthcare worker and every patient. So, if you look at the five pillars of infection control, they are number one, the isolation and barrier precautions, the decontamination of equipment. There should be a prudent use of antibiotics, hand washing, and decontamination of environment. This is the picture which is being shared by it is over the front page of NCDC booklet, the National Center for the Prevention of Communicable Diseases. So NCDC Ministry of Family Health Care, they have this is being there in their book. So
Excuse me, ma'am. Excuse
then
me,
the
ma'am.
next uh,
Excuse me, ma'am.
pardon.
Are you showing this PPT, ma'am?
Yes, it is shared.
But not shared.
It is not shared. Okay.
That's why I'm telling.
Okay, it is not moving. Okay, okay. I'll help.
Okay, ma'am.
Let me do that.
Goldie, your microphone is on.
You are not audible, ma'am.
Now it is available. It is visualized, ma'am. Hello.
Okay.
Yes.
Okay. It is available now?
Yeah, ma'am.
Okay. Sorry, sir. Actually, because of the weather problem in this area in Mohali today, we had a big storm, so there's some glitches in the
Goldie,
net
your
connectivity.
microphone is on.
Okay,
No
sir.
issue.
So as
No
I
issue.
was showing
Continue.
the HIC committee of my institute, so the purpose, what was the purpose of formulating such committees? Because it provides a forum for multidisciplinary inputs and cooperation because we are involved the every discipline, every specialty, particularly medicine and surgical, and we have to involve the OT services, pharmacy, antiretroviral therapy people, ART people. So they all can give their inputs, and by the cooperation of everyone, we can have a good IPC team. So then information sharing to recommend and monitor all the infection control activities in the hospital. So this committee, as I have shown earlier in the first picture, the members of the committee of this committee, the chairperson of this committee should be the head of the institute, which could be the director, principal, or the medical superintendent if it is a medical college. Then if it is some hospital, the tertiary care hospital, then the SMO, the senior medical officer, should be the chairperson of this committee. Then a microbiologist should be the member secretary. There is a requirement of an infection control nurse who will be providing a link between the who will be working at the ground level for this. And whenever the meeting of such committees happens, the minimum 60% of members should be there. And ideally, this committee should meet once every month. So, what are the objectives of this committee? What is the idea behind such type of committees? The idea is number one, as I told in my first slide only, our idea is to reduce the infection rates which are acquired in the hospital and which can be easily avoided. Then we have to establish the endemic baseline rates so that some action plan could be made in cases of the outbreaks, like for example, recently in Mohali there was an outbreak of cholera. So this team has to quickly identify, yes, it is an outbreak, and what are the steps which is to be taken. Then the team should identify the risk factors behind it. Then it should be able to persuade the medical personnel. And so what actions? Then evaluate the control measures and document the quality of care, and also we should know the NCI rates of the hospital. So what is NCI? NCI is nosocomial infections. Nosus means disease and comion means to take care of. So these are the infections that occur during the hospitalization, and they were not present. They were neither present nor incubating upon the admission. When the patient was admitted, they were not present, and also they were this infection was not in the incubation period. This we need to uh, uh, check before labeling it as NCI, because sometimes the patient is in the incubation period, and if then in that case we are wrongly labeled it as a nosocomial or hospital acquired infection. So if we look at the working definition, HAI, that is a healthcare associated infection, or nosocomial, what is the working definition? It could be a localized or systemic condition that is acquired in a hospital or healthcare facility, and that was not present or incubating at the time of admission to the hospital more than 48 hours for most bacterial infections. So if the patient, in case sometimes we need to ask this history, particularly we need to check that at least 48 hours have been spent in the hospital before making it as NCI. And if it is an OPD patient, then it is shorter hospital time. So CDC has listed 13 major categories of nosocomial infections, out of which there is a number, there's a huge list, but these 13 are the major ones, which is including the UTI, surgical site infections, there could be pneumonias, there could be bloodstream, bone and joint infections, CNS infections, and the list is there are another other infections also. So, but primarily patients they are complaining of SSI, UTI, there could be BSIs, which are generally being reported. Now, the question is, what are the sources? How this patient, when it is being hospitalized, how the nosocomial infections have been acquired? What are the sources? So, number one, it could be the patient's own flora, and let's say a bedpan which is being shared between the two patients without decontaminating, this could act as a source, and taking the normal flora, it could be transmitted from one patient to another. Then there are like catheterization. Sometimes the catheters, urinary catheters, have been introduced, and if the care of this catheter is not being done properly, then the flora which is residing over this periurethral area, it would get a chance, which is the normal flora present, and if now this area would get contaminated, and it would get chance to enter the urinary tract and causing UTI. So patient would land up in more trouble, because let's say there was some urinary retention because of which catheter was inserted, but now this catheter itself has become a source of infection. So then this doctor or nurse, who could be themselves, they could be the colonizers, their hands are infected, and through this doctor only can act as a source of infection, or the healthcare workers who are dealing with these patients, they are also acting as a source if they are not taking the proper infection control practices, are not being implemented properly. So that is how, because even a healthcare worker can be a source of infection. What are the two major components of any infection control program which you want to run in your center? So number one is the prevention, very, very important. We should always try to prevent it by uh, following the standard precautions. Then another key factor is the surveillance. The surveillance should be done. Uh, am I audible?
Yes, ma'am.
Yes,
Audible.
ma'am.
Okay, so these two components we should remember. One is the prevention, and another is surveillance. So, firstly, I'm coming over to surveillance. What is surveillance? Which is, as I said, it is a key measure in any IPC program. So, it is a continuous systematic collection, analysis, and interpretation of data on specific health-related event. And once this analysis has been done, it is the duty of this team to timely disseminate the information to the stakeholders who can improve the outcomes. So the surveillance loop in any healthcare system. If some event has occurred, then we should have a system where this every data should be collected in the form, by some form. You should have some incident form available for the particular healthcare event you want to collect the information. There should be a form available for it. So the data is collected, and then this surveillance team has to analyze, to look for the root causes which were there. They will give their feedback, their recommendations to the final team, to this HICC committee, and the committee has to take certain actions so that the event can be reduced, and we need to check whether by taking those proper measures the event has reduced or not. So I am sharing one example. For example, like surveillance only, we have collected this data of needle stick injury, because this is a course of the healthcare waste management, and you all are aware of the sharp injury, and that is why the puncture proof white container, which is specifically recommended for the collection of the shafts. And in spite of this, there are so many nursing students who are reporting needle stick injury to our to me or to my infection control nurse. And we have, so when the so we started the surveillance, and we wanted to know how many incidents occur in every month. And yes, this data is probably underreported also, because many students, they were afraid of reporting. There is some phobia that some people say, because HIV, HBV, HCV, these are the bloodborne, and people are phobic that I should not tell anyone that I have got exposed to the blood of a patient through a needle. So I must say that maybe the data is underreported also. So this just an example how a surveillance is done in any institute. So we tried to we collected this data, and how we collected this data, because we have this incident form. We have an incident form of our institute, the needle stick injury, blood, and the body fluid exposure form. If any person who is being exposed to a needle stick, there is any blood exposure or any body fluid for ascitic, any blood splash, then this ideally the flow chart is this person has to report to the infection control nurse. And also we have given the option of ART center, also the antiretroviral center. And this form is available where we ask the information that regarding the immune status of this particular person, how this particular exposure has occurred, whether it was during any recapping procedure, whether it was during giving an injection, or sometimes accidentally. We have come to know like some of the funny incidents also, that a student who was just standing behind one student, and when he turned back after putting up the injection, this needle pierced accidentally. So this is surveillance. You need to collect the data through a form which should be available with you. So first of all, you should have a data capturing form with you. And once this data is collected, then the second point what we have to do is we have to, from this information, we will try to make a root cause analysis. So because we have asked the patient how did the injury happen, so we try and to whom it actually happened. Uh, to let's say he was a nursing intern or a senior doctor to whom. Then we also ask what time of what shift it was, whether it was daytime, morning time. So we try to make a root cause analysis. And finally, this information is being shared. So this is surveillance. You need to collect the data, you make analysis, it try to find out the root cause behind it, and finally submit your feedback report for the action to be taken, so that in future we can recommend, we can reduce the incident. So this is how, because we have ICN working and who is being taking pictures of all the wrong things which happen. So this is regularly being told to cut the needles immediately after they are, so they were collecting the needles in the tray. And of course, if such type of practice is being followed, there is a very high chance that the person could get a prick. Then there is another where again needles were there, the catheters were there in this whole tray. So again, a fair possibility of acquiring an injury. So this is one more we noticed, and that is why we have in our institute we have given the portable needle cut. We have given those hub cutters, and we have repeatedly telling immediately once this once you the work is done, they should have follow the practice of cutting the hub immediately. But because of the I don't know the reasons they were giving, and NSI incidents was remarkably, like it has seemed to be increased, particularly in the last 2 months. We saw more rise. So this is the whole thing I wanted. This is just an example which I wanted to tell you how the component, which is a very the surveillance component, how is it working? So the team has to work daily. We need to make the rounds and we need to check that how, because the incident form only cannot help, because some people might try to hide the information. And that is why your regular surveillance to the at the bedside and checking the activities, how the people are actually performing their duty, that could help you to come to a conclusion. So that is why we tried to make out our RCA, and we just found out that yes, the lack of concentration was one of the cause, and yes, improper disposal, there were poor practices, and what corrective actions then we recommended. We wanted that all our healthcare workers, they should be immunized with hepatitis B vaccine. And in our institute, we have the hepatitis B immunoglobulins also. They are available in case some major injury happens, then we should be, preventive measures should be ready. And we also therefore education is the basic thing. So this HICC team always advocates that the regular trainings of all the healthcare workers, it should be done so that they should know the how to use a hub cutter. And because getting an injury, it is so much of mental trauma to the person also, and economic burden to to the health, the stakeholders. So this is this was just one example of the surveillance, and therefore we should always have these, like in our hospital, because it is being attached to the civil hospital Mohali. We have these boards available everywhere in all the wards and the emergency of our hospital, which are showing that how what are the steps which should be taken if a person gets a needle stick injury. And we have told to inform the ICN so that all the details could be captured and further necessary action could be taken. So if I say the what have you the crux is, be needle smart. Do not recap. Recapping should never be done, and if at all it is required, it should be done through a single scoop method. Do not bend. Do not remove and transport, and never reuse it. So this was one component, that is just an example of the surveillance. But another very, very important component of this IPC, infection prevention and control program, is the prevention. So we are looking for the prevention. How can we simply prevent it? Then so the term which is now being used, it is called standard precaution. Earlier the term was universal precaution, but now the universal precaution, it is not being used now, and we are using standard precaution. So what is it? It is irrespective of the patient's information, whatever you have, whether this person, if even if you are very much sure that this person is not carrying any infectious organism in its secretions or in its blood, then also it is your duty, whenever you are dealing with the patient, you should follow standard precaution while providing care to all the individuals, all the specimens, all needles and sharp, irrespective of status. Because there is so many terms which are there, like in window period, when a person might be positive for some infection, but he will not, if you look at the laboratory test, he might come negative. So that is why agar aapko, even if the documented evidence that all the markers are negative, still it is always a good practice. You should follow the standard precaution for all the patient whom you are providing care. So standard precaution is the one term, and under this standard precautions, what are the components which are used? Hand hygiene is the most important, and everybody has, there is a evidence proof of the fact that hand hygiene can significantly reduce the number of HAIs, and by this simple practice, we can achieve our goal. So then number two is the personal protective equipment, then biomedical waste management, which you all are very, very well aware of. Then if there is any spillage in the lab, that should also be cleaned properly. And as I said, the five pillars, so disinfection of all the patient care items, it's very, very important. Environmental cleaning, respiratory hygiene and cough etiquette, and last is the safe use and disposal of the sharps. So coming over to the first one, and before that, see, there is one term, the standard precaution, which is to be applicable to every patient. But then there are certain patients which need precautions above the standard precaution, and that we call the transmission based. So if you are very much aware that this person is positive, and for example, mm, there is a that you are performing a procedure where there is a risk of airborne transmission, aerosol production, then you need to take certain more precaution, like you need to wear N95 mask in that condition, and maybe you need to do the double gloving. Maybe you need to wear a whole plastic apron. See in this figure, you can see there is a whole apron because there is a risk that there could be a contact with the body fluid of the patient. There could be splash. So that those were the standard. But if you are anticipating any other major exposure, then you should also follow the transmission base. If the contact is there, then apron, then droplet, N95. Then in case you are thinking droplets could be there, so you can more mask and all. So, as I said, the standard precautions which are available, which are to be followed for every patient, and because we have to assume the blood and body fluid of any patient, it could be infectious, and that is why, depending upon what type of, like if you have to simply do an examination, then you can wear a non-sterile gloves also. But uh, it, let's say if it is an aseptic procedure, then you have to wear a sterile glove. So you have to analyze what is the exposure which is happening and what type of PPE a person should wear. So till now, I would say no person can do everything, but everyone can do something. And to prevent these infections, we can have the simple thing, and that is the hand hygiene, which is am I audible?
Yes, ma'am.
Am I audible?
Yes,
Yes,
ma'am, you
ma'am.
are.
Yes, ma'am.
Okay, thank you. So everyone can do something, and so if I say the hand hygiene is the one which we can, the simplest and the very effective measure, clean hands, it can save lives, and it is our duty to keep our hands germ free. So now there is this picture, how this healthcare worker who has there is a failure to clean the hands, and he has actually transmitted the infection from patient A to patient B from his contaminated hands. So that is how the need for hand hygiene it is required. And CDC has said hand washing is the single most procedure for preventing the spread of infection. And if we look at the Association of Professionals in Infection Control and Epidemiology, they have also said it causes a significant reduction in carriage of potential pathogens on the hands, and thus can result in reductions in the patient morbidity and mortality. So this is the Hand Hygiene Day, which is on the 5th May every year. It is being celebrated, and in our institute also every year from the last 3 years since I have joined the institute, or like my institute, it started in 21 only. So we are celebrating the Hand Hygiene Day, and this person who is standing in the center, he is our infection control nurse, Mr. Gagandeep, and these are the nursing people who are there. And we like conduct a lot of activities on the hand hygiene day. We can have a we conduct very various training awareness programs, so that the attendants of the patient also be aware that how this small practice can help. So, what are the 5 moments of hand hygiene? Remember, before touching the patient. So, if you're going to the hospital and you want to touch the patient, make sure you perform hand hygiene. Number 2, if somebody has to perform a aseptic or a clean procedure, so before that, it should always be done. Then, if there is a body fluid exposure, after body fluid exposure, the hand hygiene, because otherwise, if the person has been exposed to a body fluid and without cleaning the hands is moving to the second patient, he will transmit the infection. Then after touching the patient, So people, what they do after touching the patient, everybody remembers to use the hand hygiene, but before touching the patient, nobody remembers because they said, okay, abhi koi problem nahi hai. But after touching, everybody thinks, oh, I have touched. So before touching, one should always remember before touching also. And last, if you also touch the patient's surrounding, his bed, his railing of the bed, then also you need to perform the hand hygiene. And see, we have also done a number of studies have been done, and if your hand is contaminated, there could be so many like 10 to power 4 to 10 raised to power 6 CFU colony forming units of the microbes, which is there on a contaminated hand. And our idea, the acceptable limit, we just want it from best is 0, but if not, at least 300 CFU. We want only that much contamination, but many of the times it has been observed that the hands are so severely contaminated and they are the main source of infection. So, and also if you do not do the practice in a correct manner, then there are a number of areas which are missed during the hand washing. Let's say the interlaces, the nails. So these are the areas which are missed, and that is why WHO has recommended a proper how to hand wash, which the procedure which will take 40 to 60 seconds, and if it is a hand rub which you are using, then it is 20 to 30 seconds. So hand wash, there is one mnemonic, Suman. Suman is S is Sida, U is Ulta, M is Muthi, A Angutha, and N is nails. So this is the one mnemonic which is always being told in many of the trainings and even to the senior doctors. They are, so that is why I also thought of telling about this mnemonic, which you should remember before whenever you want to do the hand hygiene. And once the let's say if your hands are visibly soiled, then of course you have to do the hand wash only. But if it is, if you just want to like simple procedure, then hand rub using a alcohol based. Minded the hand rub, it should be done a alcohol based hand rub, and that is why the hospital should ensure that there is availability of hand rub at the point of care. अगर आपके पेशेंट का बेड साइड ट्रॉली पे there this hand rub which is the alcohol based hand rub ABHR, it should be there at the bedside. Only then you will, otherwise you would keep on looking for a hand rub before touching your patient. So then this should be available. Ideally the institute should uh, make it available, or this can be asked in the list which is being given to the patient, but it should be there at the point of care. And that is the advantage of also hand rub, because things are not available in every place. So hand rubs are there at the point of care, and that is the better thing. And but of course, there is some limitation for this hand rub, and that is why wash is considered to be more. It is more. It is able to reduce the microbes better. But then also, if whenever you are performing the hand wash, then if you close the tap after doing the hand wash, then you have again contaminated your hands. So make sure either you use a absorbent paper, the absorbent paper should be used, or you can use your elbow. And these are the pictures of the scrub stations where the scrubbed elbow based this tap is there, so you don't need to touch the tap once the procedure is done. And now that the latest technology, the sensors are there, which get automatically closed once the wash is complete, so you don't need to touch the tap again, because you can see in the last picture the sensor based technology is there which will do it on its own. So then also, whenever you are working, bare below elbow. Bare below elbow is a must. A person should make sure there should be short sleeves, because if your sleeves themselves are contaminated, because in winters we have seen people who are wearing the sweaters who are not being washed, and then their clothes, the clothes of the healthcare workers, they could act as a source of infection. Then the long nails, the rings or wristwatches, and people they carry it on the OTs. We have captured, we have caught people who with rings and wristwatches in the operation theaters, and that is a very, very wrong practice. It should be a bare below. Uh, then again, we don't recommend these bar soaps to be used as hand washing, and if it is a scrubbing, make sure it should be a povidone iodine soap, not a normal soap. A normal soap cannot act as a hand washing, so then one should, and particularly for scrubbing purpose, make sure it should be a povidone iodine solution which is used as a surgical scrub. So come after the hand hygiene, because I said if I look at the standard precaution, the first and the most important is hand hygiene, and number two is the personal protective equipment, which is including gloves, heavy duty gloves. There could be a surgical mask, N95 respirator. There could be plastic apron, linen, disposable gown, coveralls, goggles, face shields, caps, shoes, gumboots, and the shoe covers. So then, okay, one thing, if you need all this, let's say when the COVID was there and those persons who were involved in the patient care of the COVID patient, they need to don PPE before entering these risks. So, what should be the sequence for donning? That is very, very important. So, firstly, the gown, then the mask or respirator. Number three is the goggles, and last is the glove. Mind it, when you are donning, the gloves should be the last one, and if you are doffing, then the gloves should be removed first, and the last is then followed by the face shield, gown, mask, and last, the while when you have done the doffing, hand hygiene should be done in case of the doffing also. Then what is the then as I said, this IPC team, IPC committee. So then this committee has the role that this PPE should be available for the healthcare workers. They should ensure this. The head of the committee, the medical superintendent, they should ensure that PPE is available for the use. And but again, you should be very judicious for what type of PPE you would select for the activity which you are going to do. So that will depend upon the type of exposure. Let's say if you are anticipating some splash or there is just a touch, and if there is some isolation precaution, then durability and appropriateness. If like you suspect that this thing would get tear off, I have to stand there for a long time, I want more durable thing. Then fit is also very important. Otherwise, it would get tear off. So fit is also very important. Then the gloves, as I already said, if it is simple examination, a non-sterile glove is sufficient. But if it is an aseptic procedure, one should take a sterile glove. And if it is some like major cleaning or some the spillage purpose, then the heavy-duty gloves should be there. So this PP, all type of PP, this committee should make sure that they are available and they are being taken. Then this is a simple images how to don the gloves also. So every time the IPC says that ऐसा नहीं है कि आपने during the donning also you have contaminated the outer portion. Whenever you are donning, make sure that you are touching only the inner side and you are not contaminating the outer side of the glove. So it is effective for the patient. So after the hand hygiene and PP, the third one, which you all are probably very well aware because this is the course of the healthcare waste management, and the third is the proper disposal of the biomedical waste, and that is the waste which is generated during the diagnosis, treatment, or immunization of human beings or the animals or in the research activities. So, because they said separate harmful and infected and harmless and non-contagious, because 85% of the waste, it is non-hazardous, and if you mix this 15% of waste with the other non-hazardous, you are actually making everything hazardous. So therefore, segregation of the waste is very important. So in my institute, we have made the BMW points. So there are the BMW generation points. So every ward emergency, wherever the waste is generated, a point has been given. And there are two blocks in the institute. So in block 1, there are 45 points. And in block 2, the 23 points are there in the block 2. So this is one example where the waste is generated, the point number is given. Let's say this particular picture is showing the 24 number point, which is available in the respective ward. And we try to mention that if some violation has happened, then we need to tell ki, this type of violation was observed at BMW point this, and our director principal, she is very, very particular about it. And she has issued the show cause notices also to the violators, and there is a zero tolerance against any violation of our BMW in my institute. So the regular inspection, the regularly every because there is the faculty which is working in the medical college, they are put up on the administrative duty where they are also supposed to take a round, and during those evening rounds, not only the microbiology or the infection control team, the person who are dealing with the medicine surgery or any branch, they have to in their rounds, in the evening round of administrative round, they were being told that you have to ask the working in nursing in charge there to show all the buckets, and if something is not done properly, then it is being reported to the higher authorities. Even we are always like, if it is a red bucket, we always make sure that all the recyclable waste, they are properly mutilated. The scissors are being available at the point of generation. Near those red buckets, the scissors are there, and every plastic waste which is generated should be mutilated. Gloves should be mutilated before disposing them. The plastic bottles. Same, if it is a blood bag, we always check the autoclave register whether the bag has been first autoclaved or not, and we cannot afford any type of violation. So after the hand hygiene, PPE, the biomedical waste, number 4, infection prevention, we need to take if there is any spill, if there is any blood spill over the floors, over the, like if there is some vomit, there is some body fluid spillage, then a spill kit should also be available with the institute to prevent any such. So because if some healthcare worker, or sorry, the housekeeping staff is not aware about the spill, he might use the same mop which he is using for the routine cleaning, and then this mop is getting would get contaminated, and through this he will spread this infection to all the other adjoining areas, and that is very wrong. So that is why the spill management is also another important part of the infection prevention. So then comes the very important point in the patient care, in the good quality patient care, is the cleaning, disinfection, and sterilization. So sterilization is the highest level of infection reduction, where even the spores, even the highly resistant forms of microbes which we call spores, even they are killed. So the equipments which are used in the high critical areas, we want a good level of cleaning, and which should involve the sterilization. So the cleaning, if we talk about what to clean, so if we want a good patient care, all the surfaces should be cleaned on a regular basis when visibly soiled and when the spills occur. And then the frequency should be more in case in the ICU areas, in the high touch surfaces. So you need to just decontaminate the door handles, the call bell, the light switch, because multiple persons are using it, and then from their hands, because if you have seen the movie Contagion, if anybody has seen the movie Contagion, there this how this infection spread, it was through that door knob only, because the hands of this worker which was contaminated, and she touched the door handle, and through that door handle, multiple people got infected. So there, that movie has clearly shown that simply cleaning a door handle could have prevented the entire outbreak of that infection. So this cleaning is a very, very integral part of infection prevention. So as I told you that all the everything, the bed railings, the process of cleaning and disinfection can vary from person to person or between the rooms. So the high touch surfaces should be clean. Then you should maintain a cleaning schedule, and you should formulate it and maintain it. Then the sodium hypochlorite, which is most frequently being used for the decontamination, then one should be this how to prepare this sodium hypochlorite. That is also very important. If you want just a surface disinfection, that is, as if I said, the bed railing, you need 0.1% of sodium hypochlorite. And if it is for the washrooms, bedpans, or spill management, then the 0.5% of sodium hypochlorite is required. Then if you want a fogging, which is like we want OT cleaning, then we need to use certain better disinfectant, that is the bacillocid or EcoShield, which is there. But what we advocate, being an infection control, being a core member of the infection control team, I always recommend terminal cleaning. Whenever one case has been done in the OT, then this is a good practice to clean everything with hypochlorite, and rather than going for a fogging and uh, like simply fogging and just for 2 to 3 hours, and you make yourself ki, we have got the fogging done and now the everything is clear. That is not a good practice. Cleaning mean you need to clean, you need to wash the and once the whole day procedure is done, then take out everything and clean your whole OT. So we recommend more of the cleaning rather than relying upon a fogging process. So 10% Eco Shield can be prepared from by adding 100 ml in 900 ml of water. And for fogging, you need 20%. And if it is a surface disinfection, 10%. But again, availability of this has to be made ensured by the HICC team or the senior authority, which could be SMO. So as I said, every surface should be disinfected. Practice minimal touching. Avoid touching the surfaces with contaminated hands. Then if it is a surface disinfection you want to do, let's say you want to clean a table, so thoroughly soak a fresh cleaning cloth in the disinfectant, fold it about the size of your hand and wipe the surfaces using the journal strategies. Regularly rotate and unfold to use all the sides, and repeat the process. Then because the linen is being used so frequently in the patient care activities, and what we have seen that let's say uh, a case has been done and this linen is being contaminated with the blood of the patient, and you did not disinfect, you simply washed it, you did not care that it is there's blood, that there was blood over that, and you use the other one, because HCV, it has been seen to transmit even through the dried spots. So the linen, the disinfection of the linen is also very, very important. And all the linen, the used linen is considered contaminated. It must be bagged before sending to the laundry, and if it is a clean or a soiled linen, they must be transported separately. And if it is soiled with the blood or any other patient's fluid, then it should be soaked in 1% sodium hypochlorite before normal washing. And personal handling and collected soiled linen should wear this person particularly should wear the heavy duty gloves and mask. And once it has gone to the laundry, it should be washed at 80 to 90 for 20 minutes with a detergent in water, since this is an effective method for cleaning and killing most vegetative bacteria. So linen used in procedure requiring sterile techniques should be sterilized, and for that now that those hospitals which are NABH accredited, which are JCI, so they have the plasma sterilizers and they have a very good CSSD, the Central Sterile and Supply Department, where all the linen, all the equipment, the instrument, they are being thoroughly sterilized, because CSSD is the backbone for any institute. And if you are very sure that all the instruments which are being used in the surgery, they are very well autoclaved, they are sterilized to the benchmark, then yes, uh, you are sure that you are offering a better patient care. So every institute, every hospital should have a SOP for the laundry of their area, of their center. For example, this is the SOP of the laundry of BH Mohali, the district hospital Mohali. And we have the SOPs for all the departments like kitchen, MRD, then the CSSD, the biomedical waste management, and HICC is working separately on all the other parameters like hand hygiene audits and the PPE, which is required, which should be available, and other surveillance programs. So then kitchen is also very important. The kitchen which is serving food to the the persons, to the patients also. So we should have a training of the food handlers on food handling technique, and first their personal hygiene is very important. And we should also take care of the immunization of our kitchen staff, whether they had did the medical examination of the persons who are handling with food preparation. It should be done that like we can make a schedule that uh, their chest x-rays, their we should look for any like TB. We should get them checked for these this types of infections regularly, and also then the other infections, because there could be cuts over the skin. Then some viral markers testing could also be ensured. So we should have again an SOP for the kitchen management also, and we should ensure that they wear gloves and cover their heads with a cap. And if somebody is having respiratory intestinal disease or diarrhea, jaundice, or any skin infection, they should not be allowed to work. And apart from the chest X-ray, they are subjected to stool examination also for the pathogenic organisms and parasites once in the 6 months. So this infection control team has to take care of each and every parameter. That is how we can achieve our goal of IPC, infection prevention and control. So if you are like the engineering is also very important, because the OTs, particularly the OTs like the neuro OTs, the CTVS, the cardiothoracic, then the ortho OTs where the implants are being placed. So we cannot afford any air contamination also. You need to check the HEPA filters which are being installed in the OT. Their service is important. Simply installing an HEPA filter and then just leaving it to like this, and this HEPA filter could become a source. So very important that the regular servicing of the filters is being done, and this biomedical engineering person, they should take care that the AHUs, the air handling units, which are there in the OTs of the center, they are working as per the standards which are being recommended. So cleaning of the AHU, and then to be sprayed with 5% of the bacillocid solution. This total unit is to be aerated for 4 hours before the usage. So that cleaning of AHU, one should make sure that when the OT is not working, how often the cleaning is being done, that should be very important. Otherwise, the filters are of no use. So they are to be changed every year. Very high degree of precaution is to be taken by the engineering staff while handling any equipment related to the patient. The draft off should never stop in OT, as it will promote the growth. Then air conditioning, it should be positive pressure ventilation to prevent mixing. There should be fresh air allowance of 100% with no recirculation, relative humidity of 40 to 60%. Air changes 20 per hour, and it should not exceed 25 per hour. Then the isolation policy, the like the dengue separate dengue isolation wards, the COVID wards. We all know that many of the wards, even the OTs, were dedicated to the COVID. Then there are even the tetanus patients. We want the isolation. So every hospital should ensure. And let's say uh, sometimes there is a complicated case of measles or any other viral where the isolation or barrier is required. Then there should be dedicated rooms. For example, the open cases of TB, they all should be have a dedicated isolation rooms, and the barrier nursing should be practiced where only the disposable equipment is used, which is to be discarded and never to be reused. All the reusable things, they are collected in red bag and sent to CSSD. Their linen, we need to take care of the special linen. The linen is to be decontaminated by soaking in 7% Lysol for 1 hour and then sent to the laundry. So the room is then mopped with Lysol 7% and machine parts are cleaned with 1% sodium hypochlorite. So so we have just checked that number of, like, I've started from hand hygiene, PPE, the biomedical waste management, then the cleaning and decontamination of the equipment. As I said, that is very important. How to prepare that sodium hypochlorite every day in the morning. Somebody has to take this duty that yes, whether the freshly prepared hypochlorite is there, you need to maintain those logbooks where somebody will say, yes, today at this time, I prepared this fresh hypochlorite, because if it is, it has a very less shelf life, and if somebody has prepared it and using it, it doesn't work beyond 12 to 15 hours. So once in the morning it is prepared, it will just work for the same day only. So this thing you need to take care. If you're working with the expired chemical, then all your procedure is of no use. So the regular logbooks, regular data collection, that is an integral part. Then, because another, be sure that you have been immunized. So, one, this is very important thing that the healthcare workers, they should protect themselves also. So, so therefore, the institute should have a ideally, I must say that they can have a program where their healthcare workers should be immunized against hepatitis B, or otherwise. um it is our duty also, if you know your vaccination record, that you have been immunized with hepatitis B 3 doses in your childhood. So one test is anti-HBs, that is antibody against this virus. We can get it done, or that will tell you that how much you are protected against this virus. And if you are protected, then nothing to worry. Even if you get exposed to a positive patient, you are very much protected. But we should take care of our housekeeping staff, and we this is the duty of our institute to get them immunized with the tetanus toxoid, because they are dealing with so many waste containing all those sharp items. And also the hepatitis B should be planned. So training of the staff on the safety aspects. Then, as I said, the needle stick injury should be reported, and pre-exposure. There's a pre-exposure prophylaxis. Uh, it is that is in the form of tetanus toxoid or hepatitis B. It should be given. So then, in our institute, there is the ART, Antiretroviral Center, where the newer drug TLD, which is containing the lamivudine and the dolutegravir and tenofovir, that is available. So if somebody is like that, I have been exposed to the body fluid, the blood fluid, and that person might be infected with HIV. So ART center, this is again another important role of the HICC committee, the integral the infection prevention, that you should have a place where the post-exposure prophylaxis should be available 24 by 7. And that should be given under the supervision of a medical person, which could be the ART in charge if when the ART is working. But let's say the during the Sundays or any gazetted holiday, if ART is that person is not available, then it should be kept in any other area, which could be the emergency of the hospital. Because the PEP should be ideally be taken within the first 2 hours of the exposure to get the best benefit. So अगर आपने उसको delay कर दिया, like because the PEP was not available to the person and it got delayed, so the result is lower down. So this is again the duty of the committee to ensure the availability of the PEP doses at the right place, which should be taken well in time, and the infection could be prevented in the future. So we have discussed about the prevention, and very important, as I previously also I told you that in any healthcare setting, surveillance is the key component. And because once you capture the data, that this was the data, what were the lacunae, how it happened, why the persons who were being catheterized, they were complaining of UTI, then you need to check what were the faults when they were inserting that particular device, or they were not being taken care of. Then that is why, so surveillance is a key component to reduce the healthcare associated, healthcare acquired infections. Now, it is a foundation for organizing, implementing, and maintaining an effective infection prevention and control program in the healthcare facility. Because Lord Kelvin said, if you don't measure it, you cannot improve it. Only when you have a data, only then you can convince any higher authority that yes, see, the data has dramatically increased, or by taking certain precautions, how we were able to do so, only then you can improve. So if you don't measure it, you cannot improve. And that is why the healthcare associated infections, previously also I told you about the nosocomial infection, but if I look at for the surveillance purposes, the HICC committee take care of the 4 hospital acquired infections, and these 4 are: number 1 is the COTI. COTI is catheter associated UTI. So people think I've been catheterized, now my sign and symptom, if somebody is feeling obstruction, it will lower, but you don't know that this device could make you with another infection which is acquired in the hospital, that is UTI. Similarly, some patients, the central line, apart from the peripheral line, sometimes the central line is being inserted, but that could result in the bloodstream infection, which we call the central line associated bloodstream infection. The persons who are being put up on the ventilators, they could have ventilator associated pneumonia, and yes, surgical site infection. Once the surgery is done and you are not taking care of the wound post-operatively, or this site could get infected, and that is called the surgical. So surveillance for these 4 hospital acquired infections, it is a very they are a very critical, they are very important for the prevention. So this is another, we have introduced the COTI care surveillance program in our institute, and therefore we have made this insertion care bundle where this particular checklist is there. The ICN has to make a round and need to check whether the person who is inserting the catheter, he has performed hand hygiene before starting the procedure, then appropriate PP is there, because you might get exposed to the urine of the patient. So whether the appropriate PP was worn, then lignocaine, which was used for single use, so drainage bag. So these are the whatever surveillance you want to know, you can plan your own surveillance form for that, so that the data can be collected. And this is the maintenance care bundle for COTI. So again, we need to check whether during the time the catheter was there in the patient, whether it was being taken care, whether the cleaning was done, metal care was done, or there was no break in the drainage system. So if we find that yes, faults were there, then the appropriate steps could be taken. And so we just report that so many number of 40 cases, because if we check out that there was some lacunae in this particular bundle care approach, and taking care of the other factors, we can document that these UTIs were due to the hospital. They were the hospital acquired, and which could have been avoided if proper measures were taken. So the training and administrative, then engineering, and finally the work practice controls the PP. So last thing, because see, all the time I'm saying we need to reduce HAI, we need to reduce the healthcare associated. What is then why everybody's so worried, and why the IPC is being given so much of importance in today's era? Because another problem which everybody is facing is the AMR, antimicrobial resistance. And because even our Prime Minister has also in way back in 19 2 years back, he was in his Man Ki Baat, he also said कि AMR should be prevented. So everybody is concerned about the use of antibiotics. So we are trying that at least those infections which could be avoided, they should be prevented. So there is no extra use of antibiotic. And that is why another thing which is being implemented, which is being asked, that every institute should have an antibiotic policy. What is the policy? If I say what is the policy, it is a statement of intent and is implemented as a procedure or protocol. So this is a policy, but when this policy is about the antibiotics and it is given by an hospital, it will become its hospital antibiotic policy. That is a policy followed by the hospitals to create awareness on the antibiotics as misused to provide more effective treatments in serious infection. Because now what is happening, that so much of resistance has happened to the routinely used antibiotic, that we are giving the last resort drugs to create the simple, to treat the normal infection जो एक narrow spectrum antibiotic से treat हो सकता है. So we are using the broad spectrum, the last resort drugs for treating those infections. Like most of the times people are not aware whether for a particular condition antibiotic is required or not. Even for the viral infections, the doctors are prescribing antibiotics, and which should not be done, because if it is a simple viral, it is, or if it is a viral fever, because there are posters which say that fever does not say that antibiotic has to be taken. So you need to have a proper diagnostic services which are there, proper investigation, only then you should give the antibiotic. So, so like for example, if it is a bacterial infection, if I talk about a respiratory tract infection only, if there is a fever with more of cough and there is a purulent sputum, only then you should think of giving the antibiotic, and that too with the help of a microbiology lab. Microbiology lab uh, ideally should be there in every hospital, which should work for 24 by 7, so that the appropriate diagnosis can be made, and only the correct use of antibiotics where it is required, there only it is given. So what is happening now, that earlier when in 1940 the penicillins came and people were so happy, and it was a miracle drug, and everybody was happy, but later on slowly, the newer classes came, and cephalosporins, which were the over-the-counter drugs. So without any prescriptions, these drugs were being given, and we started observing resistance to these drugs was observed. And later on, the newer bugs have come, which is like maybe people are not like amoxiclav or augmentin, which was the drug which was given so frequently for every fever in the neonates or in the pediatric age group, and people stopped responding to such drugs. And that is why what is happening, more of the resistant strains are coming, more of the infections, and the economic burden of these newer drugs, it is so much. So now that the newer enzyme, newer bugs have come up, जैसे कि New Delhi beta lactamase, which NDM, if you people know NDM, which came in 2009 in India, and then the cases increased after that. And that is why every institute should have, there is a need of antibiotic policy in every center. You should very well, the policy should document what type of infection is it. Let's say if it is UTI, and if it is asymptomatic in a catheterized patient, if simply there is a pus cell in urine and no symptom, then there is no need to start antibiotic for that. So there should be a clear antibiotic, which should be uh, policy of the institute, that if they want to combat the drug resistance. So what are the aims and objective of this policy? To upgrade the quality of patient care by promoting the best practice in antibiotic prophylaxis and therapy, to make the better use of resources by using cheaper drugs wherever and whenever possible. Not always, but if the purpose is sufficed by a narrow spectrum drug, we should not use the broad one, and microbiology culture sensitivity should always be taken into account. To improve the education of doctors in the appropriate use, to eliminate the use of unnecessary or ineffective antibiotics and restrict the use of expensive or unnecessarily powerful ones. So, by if you have a good policy, patient will save money. So, patient saves money, and of course, the doctor would be happy. Then, so what is the conclusion? So, pathogens are there, and if you are having a good surveillance program, you would be able to eliminate these pathogens. And if you don't have a good surveillance, then the patients will be unhappy and everyone is unhappy. But in a hospital, if there is a good infection prevention surveillance program going on, then of course you would be able to curb um, your the HAI, the healthcare associated infections, and then of course everybody would be happy. So yes, a whole team is required to achieve the IPC goal. It is very difficult. I mean, number of audits we have done, hand hygiene audit, but see, surprisingly, you are going to the patient and you are looking whether this particular healthcare workers has followed the five moments. Because if I'd like I just tell you, for example, I've shown you this five moments of hand hygiene, that those five moments. So these are the five moments, and the hand hygiene audit of the healthcare workers, of the nursing staff, even for the doctors, they could be done using this particular protocol. So you just what the ICN used to do, it goes to the ward and uh, anonymously, or like without alarming the particular person, he just observed that that nursing staff whether she has done the hygiene wherever it is required. So these types of audits, they are very difficult to do. And sometimes when they just saw that ICN is observing them, they tried to follow all the steps. But yes, there could be times when they, because of the overwork, they would try to skip sometimes. And that is why together only we can achieve that the target which we want, the IPC target. And I think one should do, because that would reduce the economic burden of the patients as well as uh, for our country also. So thank you so much. That is all that I wanted to convey. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you. So shall I leave?
Excuse me, ma'am.
Shall I leave the class? Is there any question you want to ask?
Yes, ma'am.
Yes.
Ma'am,
So if there is any
up.
query, I can answer that.
Hello.
Hello,
Hello. Hello.
ma'am. Good evening. May I ask a question, please?
Yes, yes.
Ma'am, it's regarding our needle stick injury. There is a basic question, ma'am. What is the presenting policy regarding the disposal of the needles, used needles? Whether we need to cut it or we should store it in a plastic puncture-proof container and it has to be dumped like that way, and it has to be replaced with another new puncture proof container, or what ideally it should be, or whether it has to be immersed with some hypochlorite solution or not, ma'am. Kindly
See,
enlighten.
basically, the hub has to be cut using a hub cutter, and then all the needles which are collected, they should be disposed in that small needle sharp puncture proof container, and that is to be finally sent to the main your storage room. If you of course that small container, if you daily get them disposed, then so it would be difficult for the center to buy, to purchase. So what
Ma'am,
we are doing, that those small containers which are collected, once they are three-fourths filled, they are being taken to the this storage room where we have those large boxes, and they are being finally collected by our the the final disposal outsourced company. So no
ma'am.
hypochlorite usage is there, and the hub has to be cut.
But ma'am, in recent policies which has been till last year, the new guidelines has come ki the used needles need not to be burned, need not to, even the
No, no,
syringes with the hub.
burning is not done. No, burning is
Ma'am,
not done.
yes, ma'am.
Burning
Matlab,
has to be
first thing,
avoided.
it should not be burned. Second thing, it should not be immersed in any kind of hypochlorite solution.
No, yes, yes,
Third,
no hypo usage. That is what I'm telling you. You simply have to cut the herb. There is no need to burn it. Cut the herb and finally store it in that white puncture, because only the this container has to be disposed once it is 3/4 full. So
ma'am,
whatever procedures you are performing, cut all the needle whenever like needle is being used in any procedure. So cut the hub and it is being stored in that hub cutter only. Finally,
ma'am,
that hub cutter, that it would be taken out from the slot and it is disposed in that white container. No
ma'am.
hypo is being used.
In our hospital, like in armed forces, ma'am, the needle destroyers or these cutters, these have been, ma'am, discarded, stating with that key nothing to be done with this hub cutting and nothing to be done. It should be directly put in the puncture proof containers, and all these containers will be, once locked, they will be locked. They are that kind of kit cannot be reopened, and it goes to for outsourcing whatever the we have the tie up
That
with the.
finally is going to the outsource, but hub cutter is being used in our institute. Burning is not allowed. Burning should not be done because it
Ma'am,
generates those aerosols. But
ma'am.
cutting is still done. Cutting has to be done. Hub
So,
cutting is
ma'am,
being done.
so it's a institutional policy, or it, ma'am, there is a some standard guidelines, matlab, like in your institution it is been practiced like that. In armed forces it is not like. So is there any standard guidelines by WHO or any matlab, standard universal organization which states in the same
Because we are
universal?
following for biomedical this, we are following the CPCB, the Central Pollution Control Guidelines,
Ma'am,
that CPCB
ma'am,
board guidelines. And
ma'am,
CPCB has told not to burn, but to cut, and the hub cutters are being released. Lately, in our institute, the KAHO biomedical waste project has been started. So in our institute, we have been collaborated with the WHO also and the KAHO, and the hub cutters are being provided, portable hub cutters are being provided
ma'am,
on every trolley so
ma'am,
that the process can be expedited. And as a without cutting, so we don't recommend, and we are also sharing the videos how to cut it.
Ma'am,
We are like in our training programs, the ICN teaches how to cut the hub.
yes, ma'am. Thank you, ma'am. Thank you so much, ma'am.
So,
Ma'am,
see,
Control, your microphone is on.
Ma'am, the class is over.
DR Ether added for the left of mute. Control, your microphone is on.
Ma'am is joining soon. Ma'am is, there is some net problem. So ma'am is coming.
Okay, sir. Hello.
Control, your microphone is on.
Yes.
सर मैम दोबारा ज्वाइन करेंगी?
या मैम ज्वाइन करेंगे. मैम का अभी कुछ नेट का इशू से मैम ट्राई कर रहे हैं.
ओके सर.
hello, hello.
Control,
Yes,
your
ma'am.
microphone is on.
Am I
Yes.
audible?
Yeah, you are audible, ma'am.
Am I audible?
Yeah, you are audible, ma'am.
Okay, so any other question?
Madam, regarding linen disposal,
I'm not able to. Yes.
Madam, regarding linen disposal,
Hello.
hello, can you hear me, ma'am? Hello, hello,
Hello.
yeah, ma'am. Can you hear me, ma'am?
Hello.
Yes, ma'am. आप सुन सकते हैं क्या
Hello.
मुझे?
So I'm not able to hear the question which is being asked. Could you please write it?
Your microphone is on.
Your voice is audible to us. Your voice is audible to us. Or you cannot hear us. Now you are not audible.
DH5 left parent outside in right parent joined.